Awesome. Well, thank you so much. First of all, thank you for the organizers for inviting me for a second year. It's a full house, and it's amazing to see. It's a real honor because actually Dr. Houle is the one who first introduced me to endoscopic spine surgery when I was a chief resident in Boston. We had the New England Neurosurgical Society. He probably doesn't remember me, but I got enticed to endoscopy a long time ago by him. So we're going to talk about awake endoscopic spine surgery. So, I think we have to realize that, surgery is a traumatic event for both the patients, their loved ones, and a little bit for us as surgeons. And, a big key part of this is that we want to decrease that footprint, right? And we have to realize that this footprint is actually 2 feet. The first one is surgery, right? And that's the major impetus of minimally invasive spine surgery, endoscopic spine surgery, is we want to decrease the surgical footprint on these patients, right? However, there's another footprint that's really important, and that's the anesthesia, right? And this can really take people for a loop, right? You can do the perfect surgery, but if the patient wakes up and forgets what their name is and what they're doing here, right, you've done them no good. So we really want to talk about decreasing the anesthesia footprint as well. So as I've said before, failure to plan is planning for failure. So, I think a lot of us are doing these, spinal pelvic parameters and so on, but there is another whole level of planning, right? So that we can actually look at all the different corridors into the disc, if you're doing a decompression, if you're doing a fusion, and that's what we're trying to really push forward. We can know when we have anomalies before we go in, conjoined nerve roots and so on. We can actually know that before surgery. So this is using MRI technology to figure this out before we do surgery. We're really trying to push what we call patient-specific and pathology-specific, right? So just because you're very good at one technique doesn't mean that you should use that technique for every surgery. So we do this for all our patients now. We look at all the different corridors, figure out, what's the idea of surgery? Is it just a decompression? Is it a fusion? Based on that, what are the corridors that we're going to take? And this is other work that we've done. Now that we have a plan and we're actually going to do surgery, I really encourage all of you guys to have a really good relationship with your anesthesiologist. Not just the neuroanesthesiologist, but also the regional anesthesiologist. They're there, they've got all these needles and they just want to poke people, right? You can actually use them to your advantage, and this is something that you really should do, is get in touch with the regional anesthesia team, because they're just dying to do all these blocks and so on. I think Dr. Gardaki is going to talk about some of these blocks as well. So surgery is just part of the day. So we have this kind of 4-tiered system that we have for these patients. So we give them what we call preemptive analgesia even before they come to the operating room. And then we do a different type of block. So for most of the endoscopic cases and the posterior fusions, we're doing an erector spinae block. And you can use different concoctions to do this. And we actually have some evidence that sometimes the liposomal bupivacaine may be overkill for the decompressions. I don't think you need as much anesthesia for that. And then we do a spinal anesthesia. And so usually this is the anesthesiologists that are doing it, usually use isobaric bupivacaine. However, if you have I didn't see it, but I heard that you had a scoliotic case and it's hard to get in. Sometimes the anesthesiologists can't get in, right? So I had a case a couple weeks ago where they couldn't get in, and I was like, okay, let's just do general. And they're so used to now me doing spinal, they're like, no, you get in. So, you just put them prone and actually use the instrument tracking to get into there, and the patient did great. So, don't give up. And now they've gone so used to this that they want all the surgeries to be done this way. They never want to do general anesthesia. This is from the anesthesiologists. And then we have post-op pain management as well. So regional anesthesia, this is something I think as neurosurgeons we're not as in tune to. So this is something that you really have to understand and really learn and take time to talk to the regional anesthesia team. We have different blocks that you can do. Now for even my circumferential fusions, I'm doing what's called a QL block, which will give me both anterior and posterior coverage. And so first of all, why are we talking about awake surgery, right? I think that's a very important question. We know that general anesthesia is not benign. As we talked about, the anesthetic footprint is not a small footprint. It could be as big or even bigger than the surgical footprint. So this is a meta-analysis that we did looking at spinal anesthesia versus general anesthesia. We found that, interestingly, that the spinal anesthesia patients were younger, but had more comorbidities. We found certain things. We found that spinal anesthesia patients under their operative times were less. So we said, why? The nurses know that when I'm doing a spinal anesthesia case, this is a fusion, right? I only have 2.5 hours, so I got to be on top of my game, right? I'm not futzing around. Everything has to be perfect. So that's one reason for that. We found that we have decreased blood loss. That probably is due to the vasoconstriction that's happening. We have less hypotension. We don't have an induction period. We have less post-operative nausea and vomiting. We have less time in the PACU, and we have shorter length of stay. I think I see Dr. Wang in the back there. You know, he's the master of awake spine surgery, and he'll tell you that, like, if you want to be efficient, you don't have to put patients to sleep. You don't have to wake them up. Makes a big difference in how you can do, how many cases you can do, and how efficient you can be in surgery. How about fusions? So this is a paper that we published using a matched cohort. So we took the same patients with the same age. We matched them with age, BMI, and the type of surgery. And we found that the length of stay, 90% of these awake fusions, 1 or 2 level T-lifts, could go home within 24 hours. So if you're looking at doing these cases at the AAC, now you can. One of the other things we found is that 50% of these patients take 0 opioids after surgery. So they're taking 0 opioids after a 1 or 2 level fusion. And that's, you know, quite different than other things. So part of the reason is that it's kind of gradual. So it's not an on-off. They are asleep and then wake up with a lot of pain. No, the spinal wears off slowly, and you can get on top of it. So this is apples to apples, right? It's not a randomized control study. But then spinal anesthesia opens the door to a bunch of oranges that previously were inoperable, right? So this is another case series that we published, showing people that have ASA 3s to 5s with almost 100% risk of complication. Now we can get them through surgery much easier. This is a case that I posted on social media that got a lot of attention, so this is not my work. This is somebody else in Tennessee who did a kyphoplasty on a patient, had them intubated, took them 5 days to extubate her because she was 91 years old with all these different problems, right? And then she woke up with a radic. And he's like, well, I really can't do a lami on you because I could barely extubate you the first time, right? So she came to our shop. We did a awake. We didn't do this endoscopically. We did tubular, just for full disclosure. But we did a awake bilateral decompression. We got this 91-year-old home within 24 hours, and she's 2 years out, and she's extremely happy, right? So it opens up the door to a lot of patients that simply before would not be able to do surgery safely. So you know, I don't have an MBA. I don't know anything about money, but we're looking at, you know, the cost savings that can happen with this. So we found that we can save the hospital system about $10,000 per case. So if you're doing 100 surgeries a year, you're saving the health system up to $1 million. So this is a case, 89-year-old neurogenic claudication, right? Difficult case. We did this by portal. There's some rumor that you can't do by portal awake. That's not true. We do it all the time. So this is awake by portal decompression. You know, you can barely see the incisions. She went home the next day. You know, I think she was 89. I think Paul is going to talk about, you know, just doing local. So I think that just doing local, in my hands, takes a special type of patient, just like awake craniotomy and so on. But it gives you the added advantage of looking at nerve function while you do these decompressions. This is a 73-year-old. He had a 2-level lami done somewhere else, had bilateral S1 radiculopathies. He went to everybody else in the state, and they're like, oh, we need to do an A-lift or a T-lift or something. He's like, I don't have back pain. I only have leg pain, right? So we did this using the instrument tracking. We did a foraminotomy, and he's so happy, right? And there's no spinal, so you don't have to wait for that to wear off. He can go home from PACU, and he's 2 years out. So just to conclude, I think that, you know, careful preoperative planning is really important. We want to do patient-specific and pathology-specific surgeries. We want to minimize the surgical footprint, and one of the surgical footprints is the anesthesia, but also is the endoscopy that we're all doing here as well. And with that, I'll conclude. Thank you so much.
So we're going to move to Paul Houle, and then we'll save questions for the end, contrasting both techniques, because I think that once we get both sides, we can then have some good questions about it.
Mohammed, real quick question. While the patients that are going to be under spinal, you're prone. You said you might give them a little bit of propofol. You've gotten the anesthesiologist comfortable with a little propofol in the prone position?
Absolutely.
Next, a lot of people say that putting somebody with a spinal block, that you have to warn your patients and counsel them they're going to wake up with numb legs.
I think that's a very, very important thing. So,
I think they do that for a spine surgery anyway.
And it can actually be a little bit nerve-wracking, right? Because if they kind of dose the spinal not correctly, right, it could take some time before you have a neurological examination. So that's something that you have to be a little bit wary of.
More to come. All right, Paul, let's start.
All right, well, everybody, my name is Paul Houle. I'm a neurosurgeon, and I live in a small fishing village called Cape Cod. And I'm just thrilled to be here. Thank you very much for inviting me. It's nice to see a lot of old faces and a lot of new faces that it makes me really excited about the future, because I think this next generation of surgeons is really going to take this platform that we call endoscopic surgery to the next level. I'm going to talk about awake spine surgery, but really it's not awake spine surgery. It's surgery without general anesthesia. And so what I want to talk about is why I think it's potentially better for some patients, and again, why I think it's potentially better for me. And not to one-up you, but she's 94. So, I think that especially as our population ages, I don't think that we can discount the effects that general anesthesia have on our elderly patients. And not only with their physiology, but also their cognitive function. And a lot of my patients I live in a retirement area, and people are really concerned about having general anesthesia and waking up stupid. So I think it's something that we need to really think about. And I liked your slide about the footprints of surgery. We really have to think about that other pillar, because that's not how we're trained. So specific to endoscopic surgery, when I began, I started doing all of my surgeries with the patient awake, also in the lateral position. And in my opinion, I think the best neuromonitoring that you can possibly have is an awake patient. So I don't know if any of you use neuromonitoring for pedicle screws. Well, that neuromonitoring doesn't fire until you've placed that screw through the root. It tells you after you've done damage. Wouldn't it be nice to be able to know before you do damage that you're irritating a root? And so with an awake patient, when a person starts to squirm or move, and you can simply ask, are you having back pain? Are you having leg pain? Having back pain, I don't need to do anything. If they're having leg pain, I need to adjust my trajectory. And that really tells you, makes that surgery that much safer. Also, an awake patient can tell you when their pain's gone. So a lot of questions that I get about how do you know when you're done doing a discectomy? Well, I have the ability to ask my patient, is your pain gone? The other important thing is, like I said, I do my patients in the lateral position because, one, they can get themselves on and off the table. Two, anesthesia has access to their airway, so you don't have the pushback about being worried about the airway, or someone with bad COPD who can't lie prone, or they're lying on their side. You avoid all of that, all of those issues. And third, you can perform a physical exam. So again, that same question, how do you know when you're done? Well, I can perform that straight leg raise maneuver for that patient with a paracentral disc herniation. I can ask them, is your pain gone? What about your paresthesias? So it's an option that I have that I wouldn't have if I did it under full general anesthesia. So, the cognitive effects of general anesthesia are first studied in the pediatric population. And then once it hit the regular media, it sort of started to take off. So, once it hits the Wall Street Journal, it's true, right? And so, you get patients now in this day and age, especially if are suffering with mild dementia or the beginning of dementia, and they require surgery. Well, there's a hesitancy to undergo a surgical procedure that might actually significantly improve their quality of life, but they're worried about waking up with worsening dementia, which is unacceptable to them. So it just reminds me of a patient, this was just last week. I had a patient with Lewy body dementia that couldn't stand and couldn't walk and couldn't care for himself because his back hurt. He had just bad stenosis. And we did a minimally invasive laminectomy under conscious sedation with a unilateral ESP block. And the most important thing that I can tell you is that when I was doing the surgery, I forgot that the patient was awake. Okay, I couldn't tell. The patient didn't move, didn't do anything. It was exactly as if I had been doing it under general anesthesia. But when the case was over, the patient was wide awake, and they went home a couple of hours after surgery. And to me, I think that's a great benefit to that segment of the population. Also, the physiologic effects. You get, when people getting induced under anesthesia, they lose their vasomotor tone, and they've got some maybe a previously unknown carotid stenosis that can lead to stroke. And the stress of having to flood somebody with fluids to keep their blood pressure up is not insignificant. And so, in the course of my career, I've had patients that have had heart attacks after surgery, even though they didn't have a cardiac history, mainly because they've had the stress of surgery. And so that's something that we can't discount. And also, as they've gotten older, this hits a little bit too close to home, but men, when they have trouble with their prostates, and so you flood them with fluid, those patients that might have been in outpatient surgery, well, they're back in the emergency room because they can't pee and they need a catheter. We don't see those with surgery without general anesthesia. So, since this is all about me, why is awake spine surgery better for me? Well, Mohammed touched on it. Talk about efficiency in the OR. The patient's awake as soon as the surgery is over. They're ready to get out of the room. There's no 15 or 20-minute delay times 4 or 5. That's a couple of hours of your day that is just wasted. You're never going to get back. And again, the patients are going to tell you before you make a mistake. And I just can't stress that enough. I mean, we all, first do no harm. We want to make sure that everybody has a great outcome. Well, an awake patient will ensure that. Mang, wake up. Talking about practice building, Mang. So if you want to build a big practice, so people travel to see me because they know that I do awake spine surgery. I actually do get referrals from Mass General specifically for awake spine surgery. And so, patients who were not surgical candidates before now become surgical candidates because you can offer them something that's not going to create an even bigger problem down the road. So it's just a good way to build your practice. And to be honest, what the biggest barrier is not the patients, it's us. It's our mindset, it's our fear, it's our unfamiliarity with something that's new. I mean, in general, we're a very conservative bunch of people, right? And to do something new is uncomfortable, and we don't want to look bad in front of our colleagues. But we just have to get comfortable with being uncomfortable, and the fact that you guys are all here now trying to learn something different, is a testament to that fact. Then getting to anesthesia can be a hurdle, but it's easily overcome because you can turn them into your ally. Ask them, what's better for the patient, and more importantly, you get to do some new things that you weren't doing before, and that can make people be interested. So, to tell you a little bit about my history and how it sort of progressed. So, I've been doing kyphoplasty since 2003, and they were performed under sedation. And, as far as patients are concerned, a kyphoplasty is back surgery. And as far as anesthesiologists is concerned, a kyphoplasty is back surgery. So then when you go and you say, I need to do this minimally invasive laminectomy or this transfemoral endoscopic fusion, you can say, well, this isn't much more than doing a kyphoplasty. And then that gets them into a mindset. And then you can turn them into an ally. We then progressed, occasional MIS laminectomy, and I started doing transforaminal discectomies, endoscopic discectomies in about 2015. And like I said, I always started with the awake patient, and I'll tell you what the protocol is in just a second, but it's local anesthesia with a little bit of propofol or Precedex. It's really not much at all. I've now actually, with Dr. Gardaki's influence, started really utilizing the thoracolumbar fascial inner plane blocks, or ESP blocks, and those have been remarkable. And I'll talk about that in just a second. So, by transfemoral discectomies, just 0.5% marking in the skin, I do 0.5% Marcaine under fluoro while I'm localizing, and that really helps with the pain that you get when you're reaming. I think most of the pain from a transforaminal endoscopic discectomy occurs when you are doing the reaming. The periosteum of the bone is really sensitive. And if you get in that interfascial plane and you can anesthetize that, they're perfectly comfortable and they won't move, they won't complain of any pain. They get a Precedex strip and maybe remifentanil if necessary, just to keep them sedated. And then for my laminectomies, my T-lifts, my endo T-lifts, and my open cases, every single one of my patients now gets an erector spinae muscle block. And that's a 50-50 mixture of lysosomal bupivacaine and bupivacaine, every single one of them. If the patient's going to be staying overnight, they get intrathecal Duramorph. If they're going to go home, they get intrathecal fentanyl. Obviously, I'm not going to send somebody home with something that's going to last 24 hours because it's just too dangerous. So the fentanyl's out of their system in just a couple hours.
Do you give this an LP or do you do the surgery?
I have anesthesia do an LP. Again, it's a billable event for an anesthesiologist, and so they love it. So erector spinae muscle block, Dr. Gardocki is going to talk a little bit about it, but the innervation to your capsular facet joint, all your okay, I'll go fast. All your paraspinal muscles and your skin comes from the dorsal, branch off the dorsal ramus. And so it'll spread 4 or 5 levels if you get it in the correct plane. So how much and where? I use 30 mLs, 15-15 equal mixture, and then they do it at L3, and that pretty much covers every single level. Here's a video of a ultrasound-guided ESP block. You see the needle going down. They touch the transverse process, and then as they inject, you see the bolus of fluid start to lift the periosteum, and that's going to anesthetize. That's why you get the anesthetic effect over several levels. I have the anesthesiologist do ultrasound all the time. And then I'm not going to show you this, but this is actually an anesthesiologist from Florida who came up to have me do his 2-level MIS laminectomy because he didn't want to have general anesthesia. It's a long video, so if you guys want to watch it, just go to my YouTube channel and you can listen to it. But it's actually pretty interesting. You get an anesthesia provider's perspective on what it was like to have surgery without general anesthesia. So in closing, the procedures, endoscopic procedures in particular, are very suited for awake procedures, and it gives us opportunities for new procedures for us and our patients. So anyway, thank you.
So we're going to have time for like one question. Anyone have one burning question? Okay.
So for the ESP block, a good talk, Paul. For the ESP block, the other side of the transverse process, lumbar plexus. Do you worry medication can spread
medication
to the
can
lumbar plexus?
It can. Well, not the lumbar plexus, but it can go in the neuroforamen for sure. If it's not done properly, or sometimes it can extravasate into the foramen, and you can get a foot drop. You can, absolutely. But that's pretty rare.
And one final question for Mohammed Abd-El-Barr. So I tried doing these procedures in my hospital, and I got a lot of pushback. And the biggest complaint was, if I turn this patient prone and I'm going to do a spinal anesthesia, there's really high risk of hypotension intra-op in an old patient. And they said, we're not going to do it based on patient safety. What's your response to that?
Yeah, so we actually found the opposite. Hypotension is not a big issue when you're doing spinal. And one of the advantages is you can do the spinal with the patient, supine, have them actually lay down supine before you go prone, and make sure that everything is safe. And we haven't had any issue. We've done more than 100 cases now. We've only had to flip back one time, and after we had actually done the discectomy, and the anesthesiologist was like, okay, well, we got to flip back to close. And I'm like, there's nothing to close, right? So that's one of the big advantages of the endoscopic. There's no incision, right? So it makes things much
And
easier.
furthermore, if you go back to that schematic of the innervation, we're starting to actually get away from doing spinals because the erector spinae muscle blocks are so effective that we've starting to get away from that. So that's, you could just say, fine, we don't need a spinal.
I do think that there's less pushback with the way Paul does it and the way you do it, because anesthesiologists are more likely to be okay with that than that. But it's definitely two good options. Any other questions? Okay.
Hey, thank you very much.
Thanks, Paul.